Thank you for the introduction, and I'm very happy to present the results of this study, which was carried out as a collaboration between Aarhus University Hospital in Denmark and the Memorial Sloan Kettering Cancer Center in New York. We all know that we're facing the challenge that the prostate, as well as the adjacent organs at risk, move during and between radiotherapy fractions, which can cause dose distortions and which becomes even more relevant when we talk about SBRT, where we deliver only a small number of fractions. Therefore, at Memorial Sloan Kettering Cancer Center, all SBRT prostate patients are treated under intertreatment MVKV image guidance. An in-house developed software called SequenceReg is used to localize the prostate every 20 degrees of gantry rotation, and upon 2 large positioning errors, the patient is repositioned. This has been shown to reduce late bladder toxicities for these patients. What is so far still missing is the real-time dose information, including this information about motion. Furthermore, the interruptions in the treatment, of course, cause longer treatment times. On the other hand side, at Aarhus University Hospital, the dose reconstruction software Dose Tracker has been developed, capable of real-time motion, including dose reconstruction. It has previously been used online for liver treatments, but so far only in simulation studies for the prostate. Furthermore, no organs at risk have been included so far. So our goal in this study was to combine those 2 in-house developed softwares to perform the first online real-time dose monitoring during SBRT prostate treatments. So during this image-guided prostate SBRT treatments, MVKV image pairs are taken every 20 degrees of gantry rotation, and the 3D prostate position is calculated. As long as the positioning error compared to the planned position remains below 1.5 millimeters, the treatment is continued. But if it exceeds 1.5 millimeters for 2 consecutive image pairs in any direction, the treatment is interrupted and the patient is re-imaged and repositioned. We extended this workflow by adding the broadcasting functionality to the SequenceReg software, so it broadcasts or it sends the Linux state parameters and the prostate position to our dose reconstruction software, Dose Tracker. And Dose Tracker then calculates the planned, so the static, and the delivered, so the motion, including prostate and bladder dose in real time while the treatment is ongoing. An important part of this study was the validation of the real-time dose reconstruction under the 2 aspects of real-time feasibility and dose distribution accuracy. So for this, we extracted the time that was spent for one motion, including dose reconstruction. And in the second step, we compared the real-time reconstructed doses by Dose Tracker, which uses a simplified pencil beam algorithm to calculate the doses, with treatment planning system calculations, where we emulated the same motion but using multiple isocenter shifts. We included 20 SBRT prostate patients in our study, treated with 5 fractions times 8 gray and CTV to PTV margins of 3 millimeters in all directions. They were treated on standard variant TrueBeam linear accelerators with 2-arc VMAT plants. For 100 fractions that were included, for 91 of those, the motion was available. And with this, I'm coming to the results. So the average treatment time for one motion, including real-time dose reconstruction, was approximately 330 milliseconds. So per 1 second, 3 of those calculations were completed. Here we see the D95% for the prostate CTV and the V36 gray for the bladder for the final fraction doses calculated by Dose Tracker on the y-axis and by the treatment planning system on the x-axis. And we see that those calculations are in good agreement with each other, with root mean square errors below 1% for both dose volume parameters. So one immediate application of this is that we can now directly see which doses were actually delivered to the patients. And we can therefore investigate the effectivity of the motion management that has been used, so aka in this case the MVKV guidance. In this graph, we see the D95% for the prostate CTV that was planned for our 20 patients. And the blue box plots correspond to the motion including doses that were actually delivered under MVKV guidance and calculated in real time during the treatments. We see some small motion-induced dose distortions. But having this information about the doses that have been delivered, we can now compare this to motion including dose reconstructions without MVKV guidance, so without this motion management strategy. And this is shown in the red box plots here. And as expected, of course, we see notably larger motion-induced dose distortions, and for 5 fractions, the D95% drops below 95% of the prescribed dose. So we performed a very similar analysis for the bladder, where we looked at the V36 gray, The dose constraint here for the bladder was that V36 rate should remain below 10% of the prescribed dose. And as this was the planning objective, this is of course fulfilled for all the treatment plans. And it remains fulfilled under MVKV guidance for our real-time reconstructed doses. Without MVKV guidance, this constraint would not have been fulfilled for 3 treatment fractions. So in conclusion, we see that MVKV guidance reliably mitigates large motion-induced dose distortions. But as I said at the beginning, this comes at the cost of longer treatment times due to the interruptions that we have to make. So keeping this in mind, I would like to give a short outlook what could come next. So the motion-including dose is now available in real time during the treatment. And that's a fundamental first step towards real-time dose guidance, where those interruptions would only happen when this is dosimetrically necessary. And this would answer the important question, so were all those interruptions needed? And the data that I have just presented actually points into the direction that some of those interruptions could be omitted. Let's, for example, look at patient 1, where 8 interruptions in total were carried out during the whole treatment course. But we see that there is no big difference between with and without MVKV guidance for the D95% for the prostate CTV. We do see, though, that those 8 interruptions prevented one of the fractions to exceed the bladder dose constraint. So here, at least some of those interruptions were definitely necessary. On the other hand side, for patient 2, where there were even 11 interruptions during the whole treatment course, we don't see a big difference between with without MVKV guidance for the prostate and also not for the bladder. So those 11 interruptions could be omitted without compromising the dose to the target and to the bladder. So in conclusion, we successfully performed world's first real-time motion-including dose reconstruction for bladder and prostate during actual patient treatments. And we made the first step towards real-time dose guidance, where the repositioning would only happen when dosimetrically needed, and we could hopefully achieve shorter treatment times. In prospective studies, we furthermore would like to include multiple organs at risk and multiple targets, so we can investigate better the trade-off between target coverage and organ at risk overdose. Thank you.
Thank you very much. So I see there is a question from the audience.
Yeah, thank you so much for your talk. I wanted to ask,